Thank you, Lisa. We now have about 15 minutes question and answer with the previous speakers, moderated by Dr. David Michaels. Also joining us is Dr. Barbara Materna. So please put your questions for the panel in your question and answer box. Thank you.
Great. Thank you, Mitch. We've heard some excellent and very important presentations, and I also see there are already a ton of really great questions. We're going to try to get to as many as we can here. We heard from Dr. Tellier about the centrality and mechanisms of airborne exposure, and from Dr. Bonfeth about the environmental engineering controls, including ventilation and filtration, and other means to treat air that prevent exposure, and the failure to implement these controls leads to exposure and illness. And then we just heard from Dr. Brousseau about the importance of the hierarchy of controls, keeping infectious people out of the workplace, which is difficult in healthcare facilities, and then of course engineering controls, but beyond that, PPE is so often needed, and then we need respirators. The literature is clear, N95s and elastomeric respirators work, but surgical masks and cloth masks are not respirators and they're not protective. So let's take off from there. Maybe begin with a question for Lisa. Why isn't the CDC recommending actual respirators, but only surgical masks for seasonal pathogens? Is there an N95 shortage? Shouldn't the new CDC guidelines recommend respirators for these aerosol transmissible pathogens?
Yes, I think they should, but first we need to get them to recognize that those are aerosol transmissible pathogens. So that's the key, is to ensure they understand the science and that they encompass a much wider range of organisms and pathogens in their discussion of aerosol transmission, which of course then will lead to the requirement for respirators and not surgical masks in healthcare settings.
That's right. Well, let's take off from that. So, Raymond, you talked about influenza and COVID-19 as aerosol transmissible diseases. So are there other diseases, other infections you'd put in this category? And
to be sure,
need for them and for COVID-19 still?
To be sure, there are others. I've given you the example of adenovirus, for which there's a fair amount of data. Some viruses have not been well investigated for that, such as RSV. In fairness, there may be some virus for which aerosol transmission is not very important, for example, rhinoviruses, at least some strain. But some diseases that are classically transmitted by aerosol include measles, include chickenpox, which is quite common. Tuberculosis is the example by excellence of a classic aerosol transmitted disease. There are also some other diseases that are very peculiar in that they are acquired by exposure to an infectious aerosol, but then the infected patient himself does not become contagious. And so example of that would be Legionnaire's disease, the systemic mycosis, histoplasmosis, and blastomycosis and coccidioidomycosis. You would have Q fever, that would be another example of that. So these are diseases which are and currently avian influenza H5N1, which has to be acquired by exposure to an aerosol, because the virus can only replicate in the lower respiratory tract in its current form. And there has not been to date in its current form transmission between patients, but we know that the avian H5N1 could mutate to become transmissible from human to human. And one of the reasons why I'm so eager to push for aerosol protection is not only for the agents that we do know, but for new emerging pathogens that are going to come our way. And it's not bad science fiction. We've seen it often enough. Now we're still living with COVID, and there are more dangerous viruses that are lurking in the threshold.
Great. I'm glad you brought that up. Thank you. Well, let's bring Barbara into this. Barbara, it's great to see you again. So healthcare organizations say that respirators are too difficult to implement. So how should the CDC guidelines address this, do you think?
Well, at first I would point out, oops, I seems like my video is freezing. Can you hear me okay?
Yes.
Yes.
Okay, so first I would point out that respirators are used successfully by many different kinds of workers in a wide range of industries and have been for years. I think healthcare is slow to acquire the skills necessary and the recognition of where they're needed, as Lisa mentioned. So the updated CDC guidelines must make it clear that where infectious aerosols pose an inhalation hazard to healthcare workers, these are one of the necessary control measures. And they also need to make it abundantly clear that they must be used within the context of a full OSHA compliant respiratory protection program that includes all of the elements from carefully done fit testing to thorough training. There are many resources available to help employers understand how to implement respirator programs, but workers using respirators won't be effectively protected if enough effort, and that includes staffing and resources, is put into implementation of a full program.
Let me stay with you for a minute, because doesn't the California ATD standard require respirators for certain designated pathogens?
Yes, currently the standard is based on the 2007 guidelines. So for all of the designated as airborne diseases, yes, respirators are required during COVID. In addition, the standard requires respirators for pandemic, new pathogens, novel pathogens. And so COVID was brought in under that. And so there was a clear requirement for respirators. So that the updated CDC guidelines should adopt that same sort of requirement for novel pathogens while we're trying to figure out the extent of aerosol transmission. We should just presume that they're transmitted through the air.
Great, well, thank you. So let's now move back up the line to engineering controls. And Bill, it's not easy for some healthcare settings like long-term care facilities to install negative pressure rooms. So what would you recommend instead in those sort of facilities that would limit the movement of infectious particles from one room to another?
Yeah, I think that's a tough question, because the HVAC systems and in those sorts of facilities may not be much different than any other commercial building. One thing you can do if you don't have pressurization is at least make sure that that you have good seals on doors. So if you can contain the air within the space, that's a good start, and then you can put air cleaning in it. There's been at least one study I've seen of a long-term care facility where they really couldn't stop the spread of infectious aerosol from one space to another, but with high levels of air cleaning in the spaces, they lowered the levels so much that it had a beneficial effect. So you can do that, and you can try to control the airflow in the rooms too. If you've got a system that recirculates like the one I mentioned, finding somewhere else to send the return air and so that it doesn't mix with air from other spaces is one possibility.
Well, let me follow up on that, because there's a lot of discussion in healthcare facilities around operating rooms and ERs and patient rooms, but aren't we talking about exposures to both healthcare workers and patients in corridors, in nursing stations, in waiting rooms, in break rooms? Shouldn't the CDC guidelines address these risks?
Yeah, they should, and actually I would say ASHRAE standard 170, which is the basis for a lot of design, should address it. I was just appalled the first time I opened it to see that there were all of these space types in healthcare facilities that were not as well treated as an office building would. So you have low filtration amounts, you have only moderate outdoor air amounts. I think we have to recognize that we don't necessarily know where the infected people are in a healthcare facility. I think that's kind of implicit. Oh, there's an infected person, we put them in an airborne infection isolation room, but that COVID proved that wasn't the case. So we need to raise the bar for all of these other ancillary spaces, whether they're care spaces or not.
Wow, thank you. Lisa or maybe Barbara as well. Our hospital system has difficulty, with defining AGPs requiring N95 respirators for providers or other healthcare staff. Are there any comprehensive specific lists that indicate the required use of N95 respirators or other respirators for staff performing these procedures?
That's a really good question. I don't know of a comprehensive list, but I will tell you that during the pandemic, there's been lots of research, published research on what is an AGP and how much aerosol is, created by different medical procedures. I think that CDC and HCPAC would be, it would be a good thing for them to do a thorough review of the literature to determine what should fall in this category. There have been several publications over the pandemic, which I think is sort of interesting, that suggest that people are better aerosol generators than most medical procedures. I don't think we should discount aerosol generating procedures. However, some of them, maybe not all, can generate really high concentrations in very short periods of time. That's a very risky situation, since exposure is a function of both concentration and time. So a high concentration for a short time can be equally as risky as a low concentration over a longer period of time. So I do think there's better science. I think there's been some research, and I think there could be more research in this area. But I don't think we should completely neglect aerosol generating procedures altogether, simply because some on the list right now don't fall into aren't equivalent or don't generate as many particles as people do. I'm not sure that's the category. I'm not sure that's the comparison that I would necessarily make.
I agree. And, we really do have to look at the evidence. That actually relates to a question I've gotten here, which is, are federal or state occupational safety and health regulations require evidence-based practices or the use of, evidence-based hierarchy of controls to measure, identify, characterize, and manage workplace risks? And relate to that, does the CDC guidance, which isn't evidence-based, as we've all discussed today, outrank federal or state occupational safety and health legislation? And this is a big problem. If OSHA issues a standard, and OSHA started working on a airborne infectious disease standard when I was running OSHA in 2010, after the H1N1 epidemic, we started reviewing all the literature and said, okay, we're going to have a standard based on the evidence, and it applies the hierarchy of controls. It's very straightforward. CDC has not done that. It's very unfortunate. They've looked at a little piece of the evidence. They've looked at what we call sort of pragmatic randomized trials, which are trials that are not really set up well to answer questions, but also you don't need randomized trials to understand the effectiveness of respirators, and certainly to compare respirators to surgical and cloth masks. And we saw that from Lisa's presentation. But CDC isn't doing that, but because of this sort of dynamic within the government, OSHA defers to the CDC, which I think is a terrible mistake, because the CDC's process is not an open one. It doesn't require a true evidentiary review. And as a result, both workers and patients are at far greater risk. It's really unfortunate. I don't know how much time we have left for.
I think we have about a minute.
Yeah, we have about 1 minute, David.
We'll do one last question. We'll big Barbara in here. That, as you know, during the COVID pandemic, a lot of facilities were not prepared. There were immediate and severe respirator shortages. Other PPE was missing. Should the CDC guidelines require healthcare facilities to stockpile respirators and other PPE so there are sufficient supplies during surges of infections and outbreaks?
I think that's a really good point. We should have known from the H1N1 pandemic and, just the normal expectation that there needs to be thought ahead of time. Overall, the federal government and state governments let their stockpiles didn't replenish them when needed. So the overall idea of preparedness, including having enough healthcare workers trained and ready, respirator ready, even if on a daily basis they're not in high risk situations, it's really important. I believe there's been California legislation requiring stockpiling, and Cal OSHA has been involved in, assisting that determination on how much stockpiling would be needed. But it's definitely a consideration that should be addressed so we're not in that situation again.
Great, thank you so much.